we've had the introduction of everybody possible. I would directly go to the questions so that we do not miss out on that. And I would want to start with, obviously we say the ladies first, so it's always the ladies to start with. But before I go into it, what are we talking about? We're talking about ensuring safety, ensuring patient safety, satisfaction, and affordability. I'm really delighted to have people from almost every background possible, but I was missing out somebody from the central government. I realized in India, when we talk about patient, one who serves the maximum to the crowd is the central government and the state government. I'm happy that we have a lady representing the Nilofer Hospital, so we'll have few inputs from her. And then the maximum hospital is always qualified by the number of the beds. After government, the second organization which has got the maximum beds in India happens to be the Catholic Mission Hospitals, the charitable hospitals. So we are missing that link out here, and I'm very sure that we will be able to do our part in the meanwhile. And then we have the colleges who are being represented out here, corporates and community doctors. To start with lady from Nilofer Hospital, Dr. Hima Bindu. Now, in the world of digital and the way we are moving towards the next level, what is your take about and how confident are you in ensuring the patient's safety?
A very good evening to all of you. I thank the Health Summit organizers to invite me. This is the second time I'm here. In fact, I was so happy that when we talk about quality, it's always there's a general feeling that the private sector, the corporate hospitals have more quality than the government hospitals or the public hospitals. So, but then serving the government for last more than 2 decades, and I had a passion to stay on and stuck up with the government, thinking that because they're serving masses, it is the real, I felt that my time in the government sector would be more rewarding for me. But then I definitely wanted quality. It's not, I was not happy for just seeing the numbers. All of us know the load in the Nilofer Hospital. It's the only tertiary care the public sector hospital which is serving to the nearby states also. We have around 300 newborns. I'm heading the department. This is the largest department of neonatology in the whole globe. So we don't realize it is the largest center, neonatal center. But I'm not proud of just the numbers. I definitely want quality myself. And just not for the patient, for our employee satisfaction, and we are sticking on. And we also want safety, so many things to happen. But I think it is definitely feasible, doctor. It's not that it's not possible. And we are looking into creative new solutions, and we can get, I'm pushing a lot of quality improvement initiatives in my department. And in the beginning, everybody said, "Ye nahi ho sakta." No, itna sara, we have so many challenges. We have crunch of doctors, the nurses, the budget is less, and we keep on asking the government. Still, the requests are, everybody knows about it. It's not that they don't know. But then things are not happening the way it should happen in a very fast way. So, but then not leaving, let it happen, let something come from top. So we at our own level, we are trying to devise and improve our own processes and push in quality. So now we are accredited center. Our department is now accredited, had now accreditation from the National Neonatology Forum, the technical body which gives the accreditation. And so we are very proud that we are the only one in the public sector.
So I'll take an input from the Tosif. When ma'am talks about that we have a safety and we are getting accreditation, everything else comes with a price. So you pay the price for the safety, you pay for the price for the satisfaction accreditation also. And then we are talking about affordability. How do you balance that out in your center?
So honestly speaking, when we talk about safety, like you said, it comes at a very high cost. Yes. When I say safety, there are multiple levels of safety. There is medication errors. Now that is the biggest cost factor for any healthcare system in the world. In fact, the burden is considered to be about $42 billion in the world. Just medication errors alone and the financial burden of that. Now to avoid that from happening, for instance, one of the hospitals that I really know well, Green, I'm not sure if it's represented here, they have one nurse whose only job is to administer medicines, which I think is a fantastic idea. But try implementing that. Now they have 300 newborns. Try implementing one nurse to do medication. It's not possible. Even if you say 10, that means you you are going to increase your healthcare or healthcare personal cost by 30 times what you already have. You have 30 nurses. You cannot do that. So if you really want to invest in patient safety, that's a lot of money. Some hospitals are getting around it by adding what we call an infection control cost. Because you have to use a certain number of masks, gloves, sterilization liquid, everything costs money. That is not built into the cost of healthcare.
The reason is we have a media which is slightly biased, if I can afford to say that. We have headlines which come up, Dengue patient after paying 15 lakhs dies off. And I say, I can sense it out as a clinician who handles dengue every day that this was a case of MODS. And 15 lakhs is too less an amount to be handling the MODS for. So in that case, because I'm in Apollo and every time I hear everybody talking about this cost, and I realize it when I compare to my Western counterparts, I believe that we are giving much better care at 1/10 of the rate. So I have Dr. Vipin here, Medical Director of BBR, and he has some facts about the safety in the patient management. So what's your intake on that?
Good evening. Anyway, just to introduce, I'm Dr. Vipin. I'm actually an orthopedic surgeon and a hand surgeon. I'm very passionate in treating industrial hand injuries. So I'll be able to speak about the safety of patients, but daily I speak about the safety of the workers also, because that's how they end up with me having very bad injuries. Anyways, with the rest of all my family members who are doctors, we run a hospital in Palanagar, that is BBR Super Specialty Hospital. And I'm glad to share my mission of the hospital, which is very close to our discussion today. That is to provide affordable, quality healthcare, accessible to all, with healthcare, human touch and ethical values. And that's what is being going on since morning, except the digital part which is missing here, but that was obvious that we have to follow the digitalization of the health market. Anyways, coming back to the safety of the patients, I mean, one of the motto of the NABH hospitals is the safety and quality of healthcare. So definitely once we are with the NABH accreditation, the safety is the most important aspect of the patient care. Safety in terms of, once we know the international guidelines, we need to follow the international patient safety goals. And this we can follow by the HERA scale. The HERA scale is the hazard identification and risk management scale. That goes on, like we have criteria how to assess the risk management, problems for the patient in terms of the level of risk and the intensity of the damage caused by those risks. So regularly, if you keep making the assessment of these criteria, definitely we'll know what are the patient-related risks, what are the internal hazards, what are the external hazards, risk because of a breach in the HIC policy, that is hospital infection policy, because of a breach in the security policy, because of a breach in the incident reporting policy. So once we identify this and make a strategy and where we assess and do a scoring regularly, definitely we can identify where are the problems and we can make the corrective measures for the same.
Thank you, Dr. Vipin. It's a delighted to have two orthopedic surgeons sitting out here, and next is Dr. Vishnu. And I would want, when Dr. Vipin was talking about it, both of them the orthopedic surgeons sitting in front of you, he was talking about human touch. And I assume the time digitization comes, the human touch decreases. And then somebody was talking about it that, we can, instead of having a thing typed, we can have people voice recognition. How does day-to-day make sure that human touch is there and digitization make sure that the human touch is not abolished? Dr. Vishnu.
Before I talk about the human touch, I would want to quote some interesting research article. In 2012, there was a systematic study connecting all three topics. It was one of the biggest study ever undertaken in about 680 hospitals in Europe and US. They interviewed about 30,000 nurses and more than 100,000 patients. And two important things came out of it. What gives the best patient satisfaction, safety and quality. Two important things were nurse-patient ratio, and second thing was the work experience of the nurses in the hospital. So they found that any one increase in the nurse-patient ratio is increasing the number of medical errors and decreasing the patient satisfaction. And then most importantly, where the experience of the nurses was good in the hospital, all these three things improved. So connecting this to what day-to-day does. Day-to-day is a digital, cutting-edge innovative digital product. But most importantly, we have also identified that human touch is very important. That's where in our 3 C's we have 1 C which is called care. And care is exclusively undertaken by the nurses who will exclude, select and train in the empathy. In fact, if you see our own medical curriculum, we are not trained in empathy, we are not trained in communication, we are not trained in ethics. I think recently, last year, MCA has come up with that curriculum called 8Com, but still nurses are not taught that. So that's one of the biggest factors. Like, if you can be very empathetic and have that compassion and communication, that really improves all these factors. So that's what we are trying to bring in, the care coach concept, whom we train for empathy and who, in fact, in the selection process itself, we really test them for the empathy.
Thank you, Dr. Vishnu. Dr. Ahmed is here, and when we're talking about the human touch, when we're talking about the satisfaction, and I've realized that whenever you talk about the digitization and satisfaction, the cost goes up. As one of the FemCity hospital is kind of moving to the next level, how do you make sure that cost is low without compromising your patient safety and yourself?
Yeah, this is Dr. Ahmed Irfan. I am Managing Director of FemCity Women's Hospital. There are many things that goes into patient safety, and obviously, as Dr. Tawseef has also just mentioned, when you talk about patient safety, you need to increase manpower. As another doctor over here just mentioned, as the nurse-patient ratio increases, then automatically the patient satisfaction levels also improve.
And the cost increases.
Yes, the cost also increases. The cost is ultimately now, because the topic is patient safety, satisfaction and affordability. But rather it should be patient safety, affordability and then satisfaction. Because nowadays most patients, the key factor for them to get satisfied is the bill. Ultimately what the bill is costing to them. There are many measures which can be taken to improve patient satisfaction which are cost effective. One of the things that I feel is these are cost effective measures. One thing is the motivational level of your healthcare providing staff, the working atmosphere and the motivation levels of your staff, especially the nursing staff. I read an article recently where it says they questioned the nurses about certain things about how satisfied are they in their current job. And are they planning of moving to a new setup in the next few months or the next 1 year? Depending on these answers, they found that the more satisfied the staff is, that automatically rubs on to the patients as well. Yeah, the patients also feel more satisfied of the service when the nursing staff is actually working in a satisfied atmosphere. Same thing goes for the doctors as well.
Dr. Ahmed has told very clear cut. If the motivation level is high, the safety is high, the satisfaction is high, and affordability is very much within the limits. What Dr. Famida Banu, MD from Famicare Hospital, thinks about it?
Yeah, I'm basically a gynecologist and a laparoscopic surgeon working from primary health care in India to abroad, one of the best hospitals. What I have seen is one should be committed to their profession. Whether you are a doctor or a sister or even a cleaner, you should be committed. If you are committed, your performance will be best and your aim will be served. Coming to the safety, Professor James Reason has given a very good example. In aviation and in medicine, we have to follow a checklist. He has given a very wonderful model of Swiss pattern. The more the barriers, the more the safety. The more the holes, the mistakes, there will be more hazards in the end. If you read the article, you will understand in every stage you can increase the barriers, as simple as the checklist for the system, as simple as the checklist for the receiving person in the OT. These simple measures, without increasing the cost and maintenance, you can improve the safety. and time to time motivation from the team leader to motivate their team and to make them more committed. The more you are bonded to your team, attrition rate will be less. Every time you train a new person, you will be wasting your time. So you have to see that your team is coherent to you and try to develop, especially in our country, just by increasing the gadgets, by increasing the number, you may be increasing safety, but as you said correctly, you have to pay a price. There are measures coming like NABH and all those things, but most important is you should make it affordable. Research or any innovation, if it is not affordable, it won't serve its purpose. Thank you.
Dr. Satyajit, I believe one of the most important part, and we all are very conscious, is when you're having a pediatric patient, everything has to be absolutely brought to the point. Me being an internal medicine, I say 100 ml ज़्यादा चला गया कुछ फर्क नहीं पड़ता. But with the child, 100 ml can be fatal. So in that case, as a director for both children hospital, how do you make sure that safety, satisfaction equalizes the affordability?
Okay, I will introduce myself first. Myself Dr. Satyajit. Joined Hope Children's Hospital 1.5 years back. Audible? What I saw is like I got trained in FM pediatric intensive care from Lotus Hospital nearby. I can get a difference of actually. I have seen rainbow hospitals and give some of the examples. See, if you want to care, you want to improve somewhere, you need to have a set of standards. For example, I need to look up something so that this institution can get in with time. I joined Hope Children's Hospital. I saw actually the level of intensive care practices. It's kind of very pathetic. There are so many hospitals. I'm working there. So, intensive care means it has to be very intensive. See, I have now 5 paid in my intensive. Most of the time it's paid easily. I do have step-down units also 5 days. For example, some patient comes, mostly critical ill patient I see. I don't see normally the opening patients. For example, we give example of dengue seasons, but all patients they go into multi-organ dysfunction. But those patients they're coming to the ICU, most of them either a single organ dysfunction or multi-organ dysfunction. Okay, we need to have. For example, I start with some intravenous fluid. Safety point of view, intravenous fluid I am starting, RL I am starting, normal cell I am starting. It has to be titrated with the inert. Okay. For example, somebody is given, dengue patients are very fragile for the IV fluids. Both for the fever fluids, we have 3 phases of a little bit of clinical. Where everywhere the safety part is concerned. I'm concerned with safety. IV fluid manipulation, I'm concerned with the febrile. Critical phase, I'm going to concern with all the complications.
That comes with the cost. See, that's what we are saying. When you talk about safety and satisfaction,
Yes.
the cost does go up. Is that your take, and especially in the medical sector?
Very frank, I'm not going to satisfy the client. See, there is no data, there is no study that regulates patient satisfaction and patient improved quality of care. We don't compromise with the improved quality of care. Quality of care primary. My concern is the patient should get good quality of care, even if I have failed 5 years. For example, I'm talking about the intravenous fluid management. See, I ordered 5 ml per hour. For example, is an intravenous infusion pump you are using or any syringe pump you are using. For example, it is a digital. It's a digital system. For example, you are programming the machine 20 ml per hour, 100 ml, that is up here. That means, from the zero positions, I started training my sister. For example, that is solution.
So maybe your take point is that training helps out in making sure that all 3 is.
I started my sister's training. What are the infusion for how they do for everything. For example, iron drops. You are giving iron drops. I ordered 1 ml per hour.
I'll take that point if we permit me with Sudharamna Madam, the Dean of Malaradi Medical College for Women. It's an era of women empowerment, and we have almost 4 of them dominating, even we are the majority out here. So, Sudharamna Ma'am, what is your take as a private medical college, as a dean? When you talk about patient safety, are you able to maintain it in a private setup, keeping the affordability in your mind?
Good evening. Once again, I thank the Health Summit for inviting me for the second time successively. Thank you very much. Now, to answer the question of our moderator, sir, I work both in government sector as well as in private sector. I retired as Director of Medical Education Andhra Pradesh in 2009 and had been a superintendent and principal of many medical colleges in the state, in the government sector. And post-retirement, I joined Malaradi Medical College for Women. Here I am representing as a Dean of the Malaradi Medical College for Women, whom we are trying to teach students some of the various aspects which are being touched, like human touch, ethics, attitude, communication and all that. And I think most of you here must be knowing that the batch of students who have joined in 2019, their curriculum itself is entirely changed by MCI and also by the Board of Governors who are existing, and they have a different way of approach. We are not just teaching anatomy like anatomy. For example, previously they used to give a question like describe the structure and the lymph node. Now the question given is, suppose if a patient 50-year-old woman comes with a mass in the left side, left lateral portion of the breast. So what are all the lymph nodes that can be involved? What could be the diagnosis? How you will approach? How you will counsel her? How you will tell? So at the level of anatomy itself, there are many things like early clinical exposure, talking about attitude, ethics, communication, human touch, and many things are added. But it is just the beginning. There are many teaching problems as far as this curriculum is there. There are some deans whom I can see who are trying very hard to implement it. But next, coming to your question, now I am in a private medical college, and private medical college hospitals have 2 issues. Like, we want to teach our students, show them good clinical material. So actually what we do in our hospital, the name of our hospital is Malaradi Narayana Multi-Speciality Hospital. Previously it was owned by Narayana Hrudayalaya. Now our management had taken over. It has got both all the super specialities as well as all the basic specialities, starting from cardiothoracic surgery.
As a dean, my whole question is, are you able to impart the same ideas to your students now?
Yes,
Safety, satisfaction can be managed with an affordable rate.
Yes, sir. That's what I was about to tell you. In a hospital, as a dean, because I happen to be a clinician, a physician and a gastroenterologist, I work more in the hospital rather than in the college. My just point, what I would like to say is, yes, we are able to get that empathy into our students, the value of the human touch, the demonstration, the way of counseling, like telling the patient the fact. For example, sir, one question I would like to tell is, if we are very frank and very open with our patients, lots and lots of questions will come down. And I also agree with one of the panelists who said that it is not always the doctor who is a lifelong learner. All the healthcare workers are lifelong learners. Starting from the nursing faculty to even the housekeeping person, because biomedical waste has to be managed by him. So continuous training activities, getting a feedback from the students and implementing regular training activities, and once again I accept with the people where the feedback comes. Coming to your last question of affordability, now most of the hospitals I think agree that we have got many programs like Arogyashri, Employees Health Insurance Scheme, and many insurance agencies are there who are trying to do that. At least in our hospital, we are not finding it very great problem talking about the affordability. Only the point I feel is we should be frank and tell the patient what would be the cost and not be too money-minded.
We have talked about the human touch, we have talked about the affordability. Dr. Saroja is here, and she deals as a medical officer with sickle cell patients and thalassemia patients, is what I understand. Now, definitely with sickle cell patients and the thalassemia patients requiring lifetime therapy, regular transfusions, human touch and affordability with the safety and satisfaction, too tough a call to take it, ma'am. What's your take and how's your experience?
Dr. Saroja from Thalassemia Sickle Cell Society,
Hi.
where we are catering to almost 35 patients with free consultation, blood transfusion facilities and counseling. Like Dr. Ashish said, satisfaction and affordability with chronic patients is a very, very big issue. Handling patients on basis of satisfaction is difficult. Actually, they come to us almost every 15 days, and from the time they reach the reception till the time they go back with the transfusion and medication is a challenging process where you have to cater to all their needs and see the affordability as well as safety and satisfaction. Here, in terms of satisfaction, what we are working towards is, like, we are trying from all corners, ours being an NGO, to not charge them anything, because basically we are giving all the facilities free of charge. Second thing is satisfaction. Actually, in spite of giving them all the facilities free, there are a lot of issues that come up with patients. What we can do is
Even with
we need to follow it up.
Free treatment, they're dissatisfied, right?
No, in spite of that, there are challenges.
Okay.
Free treatment is not satisfying at all. In spite of that, there are a lot of challenges. What I feel is we need to follow it up with them, because they're being a chronic patients. We need to cater to them on daily basis, advise them like what day to day. I actually like the concept where post and pre-hospitalization treatment is more important.
I think both the orthopedicians have told that the communication is most important. And I would want to hear from Dr. Vipin, is how are you able to do that? Because as a PBR hospital, when I see it, it's not a very high-end corporate hospital. So the ones which are maximum coming is the middle class group. Affordability question, but Ahmed has told very clear cut. Safety satisfaction goes to the back seat the time bill is in front of you. So how do you handle that?
Yeah, actually that's affordability is a very, the issue to be very nicely being tackled at BBR, I should say. Because that is basically the affordability comes when the cost factor is involved regarding two main things, especially in the medical cases, that is the stay and the pharmacy bills. I believe that both of them can be cut short if you very strictly make antibiotic policies and protocols and very strictly stick on to them, make a very rational use of antibiotics, give the right antibiotic to the right patient, definitely will reduce the ICU infections. Shifting the patients, getting a step-down treatment from ICUs to ANC, ANCs to room. In that way, definitely you decrease the stay. So in that way, you decrease the cost on the pharmacy bills and also the number of days. Definitely that will increase the confidence and satisfaction of the patients. You'll get, that will be like a good word going to the other people.
Lesser stay in hospital, then your investors will not be happy with
No,
you.
I am the investor. So that is the thing. Here the thing is, I encourage all my consultants saying the number of patients or the number of days is not important. The turnover is important. The number of patients going home with the satisfaction is important. And same thing in surgery cases, because being a surgeon, I would say, definitely if I am confident with my HIC policies in the hospital, wherein they are very well managed, I will be very confident to use very minimal antibiotics, just a shot or two, 1 or 2 or 3 days of oral antibiotics, faster recovery, very fast discharges, and thereby decreasing the cost again on the number of days in the hospital and also the pharmacy bills. No infections, I should say there are almost 0 infections of all my orthopedic cases in the last 16 years. I can confidently say that, just by following the HIC policies.
Next time we'll have a meet at the BBR hospital to learn
Definitely.
that trick. 0 infection is something big to accept it. I see Dr. Famida wants to say something on the...
I would like to add, to cut down the cost, we should start with prevention. Prevention is the best way of cutting down the cost. For example, there are 2 things I would like to mention. One is, being a gynecologist, we can incorporate in our government policies, give injections, vaccine, to prevent the cancer cervix. As you rightly said in the beginning, the media has spoiled the reputation of the medical profession, yet we have to improve our communication with the public and restore the confidence and start with prevention. If we can give vaccination through the government policy, you are preventing a dreaded disease. And another thing is pap smear. Make the pap smear more popular, which is cheapest test, screening test, which recommended by WHO, which stands the test of time even today. You are detecting the disease very early. You are treating it with simple measures and you are preventing the morbidity and mortality of cancer cervix. So we should start with the prevention. Second thing, coming to the technology, yes, technology adoption is indispensable. I am a lab surgeon. The more refined my technique is, the more better will be the result. Lesser will be the complication. There are various energy sources, various optics. You have to have the passion to be the excellent in your profession. So I definitely need a lot of equipment. I just cannot do only with my skill. I need the instrument. Instrument, better quality, better outcome comes with a price. So we have to balance the equipment, the cost, the outcome, in the end, the satisfaction of the patient. Each case has to be individualized and we have to have a tailor-made charges and tailor-made procedures to keep everybody happy.
Tausif, that's a wonderful point which I heard it from Dr. Fameda. She says, yes, we need to be preventive in our approach. Premier is doing very good as one of the hospitals in Anandnagar, which I see it. Cardiology unit new has come up, maternal work is going on very well doing on. How you are countering to Dr. Fameda? You are, because a curative hospital, I wonder whether they will be very preventive in their approach. Obviously, the investor's interest goes down and being a businessman. What is your take on it, Tausif?
I heard an interesting study that I was going through. I think I will also quote Dr. Vishnu's study, which he said from the US. But first, there was a study again from Texas where they tried to push patients out of the hospital and decrease length of stay, thinking they will achieve patient satisfaction. The ladies actually came back and said, we feel rushed. Why are you sending us out of the hospital so early? They don't want to go out. So satisfaction is not, you have to maintain a balance. You can't really think lesser cost, more satisfaction, lesser length of stay, more satisfaction. No, that is not right. It is a balance that we need to find. Of course, I will be boasting if I say, yeah, Premier will do that, but we try. We definitely do try. That is one aspect that I wanted to say. And I was going to go back and quote Dr. Vishnu on what he was saying from the American study. One of the findings that came up from the very study which said nurse-patient ratio is important, also said in today's day and age, we are taking the burden of patient satisfaction on ourselves. We're constantly saying, like Madam is saying, everyone is saying, we should do such and such things so patient becomes satisfied. That is always the cat chasing its tail. It's never going to happen because the patient will always find new things to be dissatisfied about. What that study recommends, and I strongly agree with it, is patient engagement. Make the patient responsible for their health. Make them take, so if a guy eats sugar for so long, comes to diabetes, and you want to treat him and satisfy him, it's not going to happen. They also have to take 50-50 part in it and say, I will control my diet, and you treat me. And then you will achieve health together. So that is what is recommended, patient engagement. And that means education, awareness of the patient, not just your own employee engagement, patient engagement as well.
Okay, that was communication and the important part of that Dr. Tausif has spoken about. I would be requesting every panelist out here to give me the final take from your side. 30 seconds, not to take more than that. So that I would be very happy giving the forum to the general people to get into it and talk their experience. I'll start with ladies first on the corner. Sudharana Madam, just 30 seconds. What's your final take about safety, satisfaction, and affordability of patients? What is the most important thing which you keep in your mind as a dean?
To answer the question in 30 seconds, still I would like to say that the patient should be properly informed about his problem because, like just now somebody else said that suppose he is something, the patient also should take part. Then continuous training, communication, and of course constant check over the policies taken by that particular institution like a checklist. I think all these three things put together will make all the three possible.
Policy and training, Dr. Saroja.
First is, I think we should, like he said, creating awareness about the health issues, preventing them, and then involving them in all the processes.
not a question, Dr. Nilofa.
Affordability is a question.
But both of you are in the public sector where there's no finances involved. So
Yeah, that's what I was hearing. I think, we don't charge even 1 rupee, and we are trying to do our best. In our place, satisfaction, I think we should take the feedback from the patients when they're leaving and keep on continuously improving depending on what they are telling us and what they really want. Because satisfaction means different for different people, what they want from the system. And we should be open to listening and try to improve your processes on a continuous basis. And as I said, because we are short of so much human resource, we are already engaging the patients and the parents inside. We don't allow separation from because I'm a pediatrician. So when the parent is separated with the child, there's so much of anxiety and they're always a doubt what the sister is doing inside, what the doctor is doing, did he give the injection or not. So they are just transparency is maintained and they are all together and have a family-centric care. And the levels of satisfaction are extremely high. And involving them decision making and short hospital stay, rational treatment, checklist for your processes, all these are very nice things to take up and they're already doing all this in our, and when they go they say dua, they take jate hai. Say that because so much of cost is involved in health outside. Ultimately most of them land up in Nilofa, especially the pediatric patients because they cannot afford ventilation and high-tech care outside and we're doing them free of cost. So definitely the levels of satisfaction in Nilofa is extremely high even though we are still short of many things, but we give that communication, we give that touch, and they are really happy because we are low cost.
Dr. Vishnu, dawa or dua, इसके साथ साथ आपका क्या take है for safety when the techie like you as an orthopedic surgeon sitting out here has been told to all of us?
Yeah, patient centricity is the new buzzword when it comes to the softer aspects apart from the technology. But how do you define patient centricity is a big problem. So I have a very simple definition for it. How do you want your patients to be treated? So if you can do that for all the patients, that's what is patient-centric. If you can tell your employees, people who are working in your hospital, that this is the definition of patient-centricity, then it makes it very easy for them because talking about so many things, they can't understand what exactly is the patient-centricity. Each person has their different level of understanding, so it has to be made very simple for the people who work in the healthcare what patient centricity means. Otherwise, a technical definition or trying to do it with process, protocols, checklists is not going to really make much difference.
Thanks. Dr. Vipin, 30 seconds.
Just to continue on the same thing, that is the patient safety goals, right? So that there are mainly 6 patient safety goals which you need today. Of course, this is all part of the NABH, but try to emphasize on that by all the staff members or your paramedical staff. That is, the 6 main things is to identify the patient rightly, to improve the communication between the health workers, to improve the safety measures to use the hazardous medication, to ensure safety surgery procedures, to reduce the risk of infections caused by healthcare professionals, to improve the
final word is
HIC. Yeah, and all this you can do it by targeted solutions tool. By this, every day you can have a checklist on them and hence increase the patient safety.
Dr. Famida.
As it is a rapid fire round, to minimize the complications, we have to follow the WHO checklist and follow Swiss cheese pattern advised by James Reason. And coming to improve the satisfaction, improve the communication.
That's nice. Dr. Satyajit.
Being a critical care professional, safety is my primary concern. Okay? And about the satisfaction, my communication actually helped me in 2 cases. I have been saved being not beaten by the parents. This you see these days, the intensive care people, they are very prone to all these.
All of us are very prone to it, sir.
So kind of communication is making the parents do it, but maybe going through it.
Yeah.
Making them going through all this disease process, then they understand that.
So you also take a point is communication is most important.
Very big.
Tausif.
I just want to underline the problem as to why we are discussing on this panel today, and for everyone sitting up there. Patient safety errors leads to 26 lakh deaths every year. Unsafe care, 26 lakh deaths. 1 in every 10 hospitalized patient and 4 in every 10 outpatient patient has an issue because of unsafe care. That is why we're talking about this. That's one. Second, rather than traditionally think about how can we ensure patient safety and satisfaction. Yes, safety is our goal. Satisfaction comes only when you engage your patient. So learn to engage your patient. So don't only train your employee, also train the patient who comes in to understand their own problem and deal with it.
Thank you, Dr. Ahmed, the final take.
Yeah, before I take the final take, I just wanted to highlight one more article that I read recently. It comes from 2016, where in US they had implemented this procedure for all the insurance patients. If the patients give a poor feedback about the hospital post-discharge, the insurance company was able to deduct 1% of the payout to the hospital. So there was a study that did this improve patient safety and patient satisfaction levels. So ultimately, what they found out was that the basic premise of this rule was that patient is always right. But what they ultimately, after they did this, they found out that the patient is not always right, and patient safety has to be given more importance rather than patient satisfaction, because different people get satisfied with different things, and it's always not possible to keep everyone satisfied in this world. So
I think that was a wonderful take point that, patients' point of view can be considered but may not be that always right. The take home which we have got it is having a committed work environment with bonding is very important. More committed the work environment is, there is higher safety, there is higher satisfaction of the patient, and affordability definitely decreases. And most important thing is a training. And Dr. Famida said is a protocolized approach is much better. Having a proper feedback is important. I usually like my rhetoric always is be preventive and proactive. Be preventive and proactive so that you don't have to be repentive and reactive. So it's most important thing is being preventive and proactive approach. But जिंदगी में एक चीज सीखी साहब, इन्हें में आप तीन लोगों को कभी satisfy नहीं कर सकते sir. Definitely boss, wife, and आपका patient. So be yourself, do your best. May God bless you. Thanks a lot. I will be very happy opening up this forum for the people who are smiling out there to come forward with the questions. I'm very sure Prem has some question for the other or anybody else, please. Do we run to our coffee now? I think over to the organizers. It's been a wonderful time. Thanks a lot.
Organization which is tied down with insurance companies to say, okay, if you do this, then maybe we'll let the insurance companies come to you. And the government is also tied down to it. And the government is very clear, we don't own it, and that's how they do it. But the good thing about NABH is, although initially it was copy-paste, it has evolved. Currently, in the next month, they're releasing the 5th edition. So they have adapted it to the local circumstances. And if you notice, they have a lot of these safety processes which should be done for patients in our country is being made mandatory. So anybody who wants to go for the NABH process, they have to adopt these safety practices you're talking about. But we're learning. We're not very good at it yet.
The problem with that is how many hospitals across the country apply for NABH accreditation.
Now it is working it out. If I can intervene, see what is happening is Arogishri or CGHS, all the tariffs are giving to only those hospitals which are NABH accredited. So that is working it out. Unless until we are hardcore cash hospital, and I don't think we are surviving with that kind of structure. I would be very happy having a take from Dr. Rao. He is the Dean from Bhaskar Medical College.
Good evening to all of you. Ultimately, it is a teamwork. Teams together is everyone achieves every small. In the patient care, everyone works, right from class 4 to the top person. Then only the satisfaction comes and the patient goes safely and happy. Thank you.
Thank you, sir. I think definitely what we talked about, sir, is kind of briefly put in the right teamwork. Dr. Kemka has something to speak it out.
So I mean, this is quite an interesting and one good take home is patient safety and satisfaction. When we have to choose between, of course, patient safety should come first. Well, one question to the doctor, like he said that, like in the hospital, it has been found that when you turn around the patient fast, it increases satisfaction level. And the doctor has observed that it's not so in case of USA. So my just small concern is because in USA, European countries, the hospital bills are paid by the government in a way. And here in case of India, it's being paid by the patient himself in most cases. So is the correlation true in case of India, which is not in USA?
I would put my point. Thanks for bringing that out. Yes, which pocket the money is coming from decides the satisfaction level. When you don't have to pay from your own pocket, you can complain. You know, I've been pushed out of the hospital, which I'm very sure Dr. Vipin's hospital will not be having it because, the lesser the time in the hospital, lesser is the bill is the concept.
I completely agree with your point. In the UK, 98% of healthcare spending is by the government. In the US, it's only 48%. The rest of it, 52%, comes from out of pocket. And there's no out of pocket in the US. You cannot afford care out of pocket in the US. It's insurance. So the insurance companies are then paying for these people. And insurance, as you know, does not always cover everything. It covers a little bit. So it's not like these people who are getting pushed out are people who are not paying anything. They still have to pay something out there. Right. So I agree that it may not correlate. But just the fact is we are not studying it. That's all is the correlation. It's not that whether that is right or wrong. We are not really finding out what it is that our patients are satisfied about and not. Like I said, even free care, they're not satisfied. And they're still willing to go pay a higher amount at some private hospital and then, be satisfied with their care sometimes. So they're willing to pay and then be satisfied and willing to get it free but not be satisfied. So unless we study our local population and find what satisfies them, we will not. So we need to study rather than go with logic.
In closing, the final thing is, in Apollo, I've been seeing it, we're doing the patient safety conference every year. And if all the other colleges, Malareddy and Bhaskar and others get onto it, we need to start talking about it. See, what is happening is, we're talking about patient safety. Nowadays, I'm always concerned about doctor safety. Last week, my senior in Kolkata has had a bad experience. Anyhow, it's a price which we all pay. I'm saying the final message I ask anybody is, how many of you do not want to have any medical legal cases against you? And everybody raises their hands. I say, stop practicing. The only way not to have a medical legal case against you is not to practice. So, talking more about it, having more conferences, having the experience of such a panelist and such an audience, probably is a good way towards a brighter future. Thanks a lot for the wonderful participation.